So good afternoon, everyone. My name is Kylie Hall. I'm going to be moderating the event today. I'm the Operations Director in the North Dakota State University Center for Immunization Research and Education, also known as CIRI. And today I'm going to be introducing Dr. Paul Carson, and he's presenting today's webinar. Dr. Carson is an infectious disease physician with over 25 years of clinical experience caring for patients with complicated infectious diseases. Prior to coming to NDSU in 2013, he held roles at Sanford Health that included Chair of the Department of Infectious Diseases, Director of Clinical Research, and Chief Quality Officer. He is currently a professor in the University of North Dakota School of Medicine and Health Sciences and a professor of practice at North Dakota State University in the Department of Public Health. And he currently serves as the medical director for CIRI for our center. So, Dr. Carson, you can begin.
Thank you, Kylie. Thank you for that introduction and welcome everyone. Good afternoon. The topic of today's seminar, and this is part of our quarterly seminar series from our Center for Immunization Research and Education, which our associate director for our center, Lauren Dibson, has been putting together for the last couple of years. We've had really a number of excellent speakers and topics on this, but I was asked today to talk about the issue of vaccine safety, and I titled this "Vaccines Under the Microscope: How Can We Know They Are Safe?" And I think, as many of us are aware, vaccine safety has really moved to kind of front and center of sort of the public debate. Even prior to the COVID pandemic, faith in vaccines was steadily on the decline. This was a Gallup poll showing, a decline from 2001 to 2020, and showing that, people were having, in this poll, one of the questions was the percentage of Americans who feel strongly that parents should get their children vaccinated dropped by 10 percentage points, and still a lot of beliefs in uncertainty about things like vaccines causing autism in children. When we look at vaccine confidence, about 50 to 60% of Americans have at least some concerns about vaccine safety. So a lot of people, that doesn't mean they're vaccine resistant or overtly vaccine hesitant, but a large portion of the population has at least some concerns. Now, that's in part because vaccines have been, in many ways, victims of their own success. If you look at this list of diseases, these were really a scourge at the turn of the last century and through the early 1900s, causing tens to hundreds of thousands of illnesses and deaths, particularly in children. And really, almost wholly because of vaccines, these have virtually disappeared with huge reductions to almost a complete elimination of many of these diseases. In fact, smallpox has been eradicated from the world. Polio is on the cusp of eradication, with only a couple of countries now still having wild-type polio. It's been eliminated from the Western Hemisphere, although threats of it coming back we'll mention in a moment. And even diseases that I used to see routinely when I was in my medical training, like Haemophilus influenza, invasive infection causing meningitis and epiglottitis, and particularly in children, is virtually gone. And doctors training now haven't seen these diseases, and certainly parents and the general public haven't seen these, and they've sort of faded from our collective memory. And as such, people are much less concerned about these things that they've never seen or heard of, and more concerned about either real or imagined potential side effects or adverse effects from vaccination. And that's led a number of people to be, to one degree or another, hesitant. And that typically is on a spectrum from people who are willing to accept anything that their doctor or medical provider recommends. I'm ready to take any vaccines that you tell me, doc, to I've got some questions or doubts, to I think I don't want these right now, but I'm not really sure about my refusal either, to people who are out to convert you that the vaccines are dangerous and that they don't trust them at all, and maybe even almost evangelists about that proposition. And in fact, the World Health Organization in 2019, again, before the COVID pandemic, put on their top 10 threats to global health vaccine hesitancy. recognizing that this is a threat to many, many gains that were made over the previous decades. And in fact, we're starting to get hints of these threats already. We've seen many outbreaks reported in the news in the United States and in other countries here, several measles outbreaks, polio making a comeback in the Philippines, polio making a comeback in Israel, polio making a comeback in Malawi after being gone for decades. And even now, a case of polio in New York not too long ago was really almost inconceivable. But this has been spurred almost wholly due to pockets and clusters of unvaccinated portions of the populace, allowing these diseases to be reintroduced. The main reason that's in multiple polls for people's hesitancy and concerns are concerns about safety. Now, we want our vaccines, of course, to be both safe and efficacious. It's not the efficacy that's in question, although not as much. There may be questions about need for a lot of these vaccines and people saying, I haven't seen these diseases, but they are really a plane ride away if we have increasing portions of the population that are susceptible. But safety is the big concern, and all of us have a stake in safety. All of us want safe vaccines, and all of us want to know that they're safe. But that sort of begs a question: what does safe mean? What safe does not mean is zero risk. There are virtually precious few decisions or actions we make in life or do that have pure benefit and no downside or no risk. I want my children to be educated. I have to get them in the car and drive them to school in the morning. Whether it's a conscious or subconscious risk-benefit calculation, I am taking the risk of driving each day or some bad thing happening in school because of that benefit of the education they'll glean. We make these risk-benefit calculations all the time, and that's really what needs to be done with vaccines. This shouldn't be a gut check problem. It shouldn't be an emotion problem. It shouldn't be a political party affiliation problem. It's a math problem. It's purely a math problem and looking at the risks versus the benefits. And in the case of vaccines, it's the risks and the benefits of exposure to the pathogens we're trying to prevent. Not only exposure, but my personal risk of getting infected and my personal risk of having a bad outcome from that pathogen versus the risks of the vaccine. And this math problem can be worked out with fairly decent detail. And that's what I want to kind of get into. So what does the United States do to try and get at that sort of math problem on are the benefits of the vaccine substantially outweighing their risks, which is the bar that we really need to introduce a product that is predominantly, or and maybe in most cases exclusively, given to healthy people. They're not usually given for the disease at the time, and that's different than when we take a drug for like diabetes or for our heart disease or whatever. There, the risk of the disease is much more imminent. So we have to look at all these risks and benefits together. And so I want to go through the journey of a vaccine from its development to public availability. And to have that become available requires FDA licensure. What does FDA licensure require? It requires that the vaccine manufacturer produce data showing the purity of their product reproducibly, that we can go from batch to batch or lot to lot, and you can show that it's the same pure product, that it's potent or immunogenic, and most importantly, that it's effective, that it's preventing the disease it's designed to prevent, and what we're talking about today, that it's safe. Now, how does that start? So the traditional timeline for vaccine development is around 10 to 15 years. And it starts really in the pre-clinical phase, before anybody actually even reaches out to the FDA. So in that preclinical phase, the scientists and the manufacturers are doing test tube studies, animal studies, trying to prove that it's immunogenic, and that the product is pure, potent, etc. Then if that all looks good, and that can take years, that can take many years to develop the proof of concept and show immunogenicity, et cetera. Once that looks promising, then the manufacturing company can submit to the FDA for what's called an IND, or investigation of a new drug or device. They can submit that preliminary study results, and the FDA will review that and decide whether or not they can proceed on with clinical trials. If they say yes, the manufacturer can launch a series of clinical trials, phase 1, phase 2, and phase 3. Phase 1 being studies in small groups of people to look to see, does it mount an immune response in humans? What's the right dose? Is there any overt toxicity in that small group of people? If that looks good, then it can move on to phase 2, which usually is done in dozens to maybe hundreds of people, looking a little more for safety signals for common side effects, looking further potentially at immunogenicity, and you may start to look at its ability to protect. And then if that looks good, then it moves on to the most important part, which are large phase 3 studies. These are typically randomized controlled trials where you have a large group, thousands to tens of thousands of people who are in a vaccine arm, and thousands to tens of thousands matched people randomly allocated to a placebo arm. If that data all looks good, then the company can submit to the FDA for what's called a biologic license application, which is usually thousands of pages of documents from these studies for the FDA to review. And that takes usually several months for them to look through these documents. And if that all looks good, experts in immunology and vaccinology and infectious disease and epidemiology will advise the FDA whether or not to approve. And if they approve, then the company can start manufacturing the vaccine. Now, this is just a different schematic of that same timeline. When you look at the approval process, many candidate vaccines never progress to clinical trials because they fail to produce the desired immune response, or they're found to be unsafe. From drug discovery through FDA approval, it typically, as I said, takes about 10 years on average, and costs nowadays around $2.6 billion to get that candidate vaccine through to licensure. Less than about 12% of candidate vaccines make it into the phase 1 clinical trials and ultimate approval by the FDA. Now, if you look at some of the phase 3 trial data, I picked a handful of different vaccines here, and I draw your attention to the last column for the phase 3 licensure studies that were done to approve these vaccines. You can see the N, or the number of trial participants. Usually this will most often be split in half, between half the participants getting the vaccine and half the participants getting a placebo control. And you can see that these range from, on the low end, the RotaShield vaccine had 4,400 total participants, to the later rotavirus vaccine having 80,000 participants. Here we have the Pfizer and Moderna vaccines with 30 to 43,000 participants. Now, when we're looking for side effects in these trials, when we're trying to get a safety sense here, there are some issues with this. So these trials have a number of strengths. They're very rigorous. They have this stepwise safety and efficacy assessment. And particularly with the phase 3, you've got really good management of bias. You've got really much better chance at having very good group equivalence. So you're much better able to measure what's the true effect of the vaccine versus just random effects. And these trials are typically powered most to detect efficacy. So you want to reach the threshold to show that it will benefit the population. Limitations are that they can't detect very rare AEs. Here is adverse events. Here is the little acronym. It can't detect very late or delayed adverse events. They're very expensive. They're very difficult to do. I've participated in many of these as a clinical trial site. Very rigorous, lots of paperwork. Lots of exacting detail to the health of the study subjects. They take a long time. And there's also limitations that typically pediatric populations and pregnant women are often studied later. I want to just point out that an adverse event in these trials is defined as any negative or untoward event following the administration of vaccine. I mean, this can be falling and breaking your hip. Anything is required to be reported in these trials. This includes true adverse events due to the vaccine and events that coincidentally follow vaccination, which we're going to get more into in a minute. But the limitation, two of these limitations I want to point out here, that it can't detect very rare adverse events, and it can't detect very late or delayed adverse events, because the trials are typically 6 months, 12 months, sometimes as long as 1.5 to 2 years. If you under the suspicion that there may be something very, very late or delayed, it's not going to detect that. Well, I want to look at those two contentions here for just a second. So first, on the delayed side effects, I'm going to make a statement here that might seem hard to believe, but I'm pretty certain this is correct. I've looked hard for this multiple times. In the history of all vaccines licensed in the US, no serious adverse event, these are things that put you in the hospital or cause death, no serious side effects have been found beyond 6 to 8 weeks after the vaccine was administered. Now, that's not to say this couldn't happen. That's not to say this couldn't happen with a novel technology like an mRNA vaccine, but this is held up even with the mRNA vaccines. We have yet to find any serious side effects that go beyond 6 to 8 weeks. And I can go into more details on why that may be later. There's one important exception or caveat to this, and it's not in US licensed vaccines. This is true for US licensed vaccines. There is a problem called antibody-dependent enhancement, which I can take questions on later if people are interested, that can be a delayed effect. It's where antibodies don't clear the pathogen very well from the vaccine-induced antibodies, don't clear it very well, and may actually, in very rare circumstances, enhance that pathogen's virulence. That has been found, for example, in the dengue vaccine, but it's rare and it's typically looked for. And that's the only thing I'm aware of that could go beyond 8 weeks, and that's not been reported in any US vaccines. Another thing that you might just take home with you is a little quick rule of thumb called the rule of 3. And this is in how you might kind of get a sense of how well the study is finding rare events. The rule of 3 states that you can be 95% confident. This is a kind of quick and dirty statistical analysis that for the most part holds true. It's not the way a statistician would approach it, but it typically tends to work. You can be 95% confident that your sample size, or N, can detect events at a rate of 3 over N or greater. So let's just put that to use here. So the example, the phase 3 trial for the Pfizer mRNA vaccine had 22,000 subjects in the vaccine arm and then 22,000 in the placebo arm. So if you use the rule of 3 over 22,000 is a rate of 0.0136%. That's also a rate of 1 out of about 7,300. So we can be 95% confident that we detected any significant or serious adverse event that occurred at a rate greater than or equal to about 1 out of 7,300. Now, if a similar rate of problems is happening in the control group, in the placebo control, you'd need even more power or a higher number there to be able to compare those two groups statistically. But the point here is that if there's something that's that rare, it should show up at about a rate of 3 over N or greater. All right. So vaccines can cause serious adverse events. So here's a partial list of some of these. So most any vaccine can cause anaphylaxis, typically in about 1 out of 1 million recipients. Influenza is noted to possibly cause Guillain-Barré syndrome in somewhere around 1 to as high as 10 per million vaccine recipients. Measles, mumps, rubella can cause a transient syndrome of idiopathic thrombocytopenic purpura, or low platelet counts, in about 1 out of 40,000. And measles, mumps, rubella and measles, mumps, rubella varicella can cause febrile seizures at fairly high rates. The original rotavirus vaccine caused intussusception, a telescoping of the small bowel in the babies that received the vaccine, that can cause a blockage and can be serious. That was in 1 out of 11,000. The newer revised rotavirus vaccines can still cause that complication, but now it's at a much lower rate of about 1 out of 100,000. But if you look at those rates, those are things that often may not be picked up in those phase 3 trials where you may have 10,000, 20,000 study subjects divided into 2 groups. And so to detect those rarer side effects, we need to move to what we call our post-licensure vaccine safety monitoring system. So the bar was met that the benefit from these vaccines outweighed these rare side effects, but we still want to know about these rare side effects, and we want to, and we may revise how we give these vaccines, or we may try and revise the vaccine itself. So we rely on detecting these rare events through our post-licensure safety monitoring. Well, what is this? The U.S. has an actually really incredible network of systems to look for safety signals after licensure. So there's ongoing mining and trolling and hunting for safety problems through a number of different systems that the CDC and the FDA use. And I'm going to try and touch on all of these here. The most well-known one is the VAERS database. Everybody's kind of heard of that. Most everybody. This is the Vaccine Adverse Event Reporting System. VAERS is a passive reporting system, which means anyone can report an adverse event into VAERS. Any citizen, anybody who thinks they were harmed by a vaccine, anything. You fell off your roof, 4 weeks or 8 weeks or 20 weeks after a vaccine, and you think that might have been from the vaccine, you can file a report. Healthcare providers are obligated to report serious adverse events. That's any adverse event that leads to hospitalization or death. And there's no really time limit put on this, although most of these reports are usually in the weeks to months after vaccine, but there's no time limit on it. Scientists and automated systems continually look through these reports to monitor for unexpected events or those occurring with more frequency than expected, and all deaths are reviewed. Then they determine if further study is required, and we're going to go into this in a lot more detail. Here again, adverse event is any negative or untoward event following the administration of vaccine, anything. Now, what this is really meant to be is a system that tries to identify patterns, and it's meant to be an early warning system. It is not a system that can find every adverse event out there. It won't find it. And there's a lot of critics out there that say, this misses a lot of adverse events, and it does, because it's passive. It's relying on people's voluntary submitting of reports. And of course, lots of the general population aren't going to bother to go through this process. We hope that we get most serious adverse events that show up into a healthcare system or that lead to death, because healthcare providers are obligated to report these. But that's not the strength of the system. The strength of the system is that VAERS is meant to cast a very wide net to try and find that sort of canary in a coal mine, or those patterns or signals. So that strength is that, again, anyone can submit a report to VAERS, that wide net being cast, and that it can serve as an early warning and hypothesis generating system. The limitations of this is that it is passive. That means it's not going to capture all adverse events. And there's really not a true denominator. You can't really get very precise rates of problems from this, because what's the denominator? What's the whole population, the whole vaccinated population? But the real denominator is really the population that's willing to submit a report, and that's unknown. The biggest limitation of this is that there is no control group, and I'm going to hammer on this point in some detail as we go through the presentation. So you don't have a control group to compare rates in a vaccinated versus an unvaccinated population. So it cannot determine causality. It can only raise questions. And often these reports lack details and they contain errors, especially when submitted from the general public. It's usually a little better when it's healthcare providers submitting this, but these may contain errors. Now, the problem with this system is that it's very misunderstood and very misused. So there's lots of articles that kind of like this one from the Harvard Political Review talking about how a CDC database, and this is the VAERS database, is fueling global anti-vaccine sentiment. And it's because people infer things that database can't do. So, here's this woman at a protest holding up vax deaths, which I'm presuming she's pulling from our VAERS database, UK similar system, and EU system, where she's saying, 11,000 deaths reported. Maybe it's even 10 times as many because this doesn't capture all of the reports. Well, the challenge here in the problem is that our brains are literally hardwired to make causal inferences. And this is how we've evolved to try and stay out of danger, is to try and find, when something bad happens to us, what caused that bad thing to happen. I use this example of Jenny McCarthy, who many of you may know. She was a MTV, talk show host. She was a B-movie actress and a one-time paramour of actor James Carey. Her son Dylan developed some kind of developmental disorder. I don't know if it's autism or something else, but she really believed that he was doing fine, and that it came after he was vaccinated. And when she, gets challenged on this, her reply was, he was vaccinated and something changed. My son is my science. And when I teach my class and I talk to my students in the first couple of classes of the first semester, I ask them, is this an unreasonable thing for her to conclude? And they squirm a little bit because they think, well, she's kind of anti-vaccine, it must be unreasonable. And I say, no, this isn't unreasonable. Any mother would do this. Any mother who thought their child was okay and something changed would want to know why and start looking for things that happened before it that might have led to that change. The problem is that that's the weakest of forms of data or association. So a different spin on that is another thing that we frequently heard, in the wake of the COVID pandemic, where people can go in and mine the VAERS database. It's a public database. You can go in and pull a report, and people were pulling a report of how many deaths were there from the COVID vaccine, as an example. And here, you'd have somebody saying, I've heard that there are over 18,000 people have died from the COVID vaccine. Is this true? No, this isn't true. We need to be more accurate in what we are saying here. The number, and I'm pulling this out from a time that people were saying this, it was about a little over a year ago. Actually, the number was like 9,000, because a lot of people that were pulling those reports didn't know how to set the filters right so that you didn't get duplicates. It's a very easy error to make when you pull data out of the VAERS database, that you can get duplicate reports. So you got to make sure you're getting, you're not counting the same person twice. But even if there's 9,000 people that died and reported in that database, that's concerning. But the other problem with this statement is that they died from the vaccine. No, it's they died after the vaccine. Now, that might seem like a petty play on words, but it's hugely different. Hugely different. So what's the difference between from versus after? This really gets to what's called the post hoc fallacy. Many decades ago, students even, up through primary school and high school had logic classes. We don't really teach that much anymore, but the post hoc fallacy was a very common fallacy that was taught in logic classes. The formal statement of the post hoc fallacy is post hoc ergo propter hoc, which means after it, therefore because of it. Now, it's called a fallacy because it's frequently wrong. The other way of sort of saying this is correlation does not equal causation. And I have the picture here of the rooster crowing as the sun comes up. So the rooster crows, the sun comes up. The rooster crows, the sun comes up. The rooster crows, the sun comes up. Does that mean the rooster is causing the sun to come up? It's a very tight correlation. No, if the rooster doesn't crow, the sun is still going to come up. But it is a strong correlation, and it happens typically, the sun does typically happen to come up after the rooster crows. To put a little finer point on this, Paul Offit, actually the inventor of the recent rotavirus vaccine and a pediatric infectious disease specialist at the Children's Hospital of Philadelphia. He's written a number of books about vaccination. In one of his books, he tells the true story of one of his colleagues at Duke University who stood in line to have his child go to a drop-in vaccine clinic because his child was due, his 8-month-old son was due for a DPT booster, diphtheria, pertussis, tetanus vaccine booster. He stood in line, and it was in the evening after work, and he got kind of tired of waiting, and he decided he's not going to have his son vaccinated. He went home, not receiving the vaccine, planning to return at a later time. Very sadly, his son died in his crib that night, presumably of sudden infant death syndrome. And this colleague of Dr. Offit's rightly observed that had he gone through that line and completed his mission of getting his son vaccinated with DPT vaccine, and as fate would have it, his son would have died that night from sudden infant death syndrome anyway, hardly anything in the world would have shaken him from the belief that that vaccine caused his son's death. But he would have been completely wrong. It would have been something that would have happened in very close proximity to that vaccine, and it would have been a very compelling case of my son was fine until this vaccine and something terrible, disastrous happened. And that would have been the post hoc fallacy. Now, it certainly would have been legitimate for that dad to have wondered, did this vaccine do this? But that's not enough. And here's really what's the issue. On any given day in America, about 540 people will be diagnosed. I'm pulling a handful of bad things out here. We could do many more than this. About 540 people will be diagnosed with the new onset of a seizure disorder. About 2,200 will have a heart attack. About 2,500 will have a blood clot. About 2,200 will have a stroke, and 8,000 people will die every day in America. So break that down a little further. Every 160 seconds, somebody gets diagnosed with a seizure disorder. Every 39 seconds, somebody has a heart attack. Blood clots every 35 seconds, a stroke every 39 seconds, and someone will die in the US every 11 seconds. So look at that when you think about how we vaccinated the population for COVID. I'm using COVID because it's such a fresh example, but we could do this for a number of other examples. We vaccinated close to 60% of the population in about 8 months. We were giving hundreds of thousands of doses of the vaccine daily. Hundreds of thousands of doses daily, millions within a matter of a few months. Layer on top of that, before COVID vaccines were ever rolled out, every 160 seconds, a new seizure, 39 seconds, a heart attack, 35 seconds, a blood clot, 39 seconds, a stroke, 11 seconds, a death. Of course, there's going to be these bad things happening an hour, a day, a week, a month, 2 months after a vaccine, just by chance alone. So it's not enough to say, my Aunt Susie, was fine, and 4 weeks after a COVID vaccine, she had a heart attack. It had to be the COVID vaccine. Well, or was she just one of the people who every 39 seconds has a heart attack that day? When you look at this further and you break down like the deaths that were reported in VAERS for COVID vaccine, this was through the end of 21. You see the overwhelming majority of these were in the elderly, as you might expect. I mean, who got the vaccine first? The elderly. Who's most likely to die? Who's most likely to be one of those 8,000 deaths every day? The elderly. So it's not enough to say this bad thing happened after the vaccine. We need to go further. We need to pull the signal out from the noise. And that's not easy. So to pull the signal out from the noise, we need to look at vaccinated people compared to a control group. VAERS does not do that, can't do that. All it can do is ask the question, is this blood clot? Is this heart attack? Is this stroke? Is this death from the vaccine? Could it be? We need to look at it further. We need to look at that with a control group. So we have other systems that help us get there, get better data, ask those questions with better data. Here are some of these other systems. First, we have several other systems that do active surveillance. So it's not just hoping and waiting for people to passively report. They're actively mining data on a regular basis. And active surveillance is proactive assessment. These are done in a variety of large databases. It's usually in a captive population, which is a truer denominator. And these can be data that can be used to verify safety signals that are generated from VAERS, or to detect 8 additional safety signals. So we don't have to just rely on VAERS and passive reporting. We can actively be looking for safety signals in large databases, which I'll get to in a minute. Let's talk about the one that I think is the most important. If you take nothing else away from today's lecture, I want you to hopefully take home a greater understanding of what this system called Vaccine Safety Data Link does. Vaccine Safety Data Link is a CDC-managed database that consists of 9 participating healthcare organizations in the United States. These are large integrated health systems that have very robust electronic medical records. They represent over 12 million persons per year. This is the Kaiser system out west, Health Partners in Minnesota, Marshfield Clinic in Wisconsin, Harvard Pilgrim System in Massachusetts, and Emory CDC in Georgia. These healthcare organizations can be asked to actively monitor for certain problems. More importantly, they can generate control groups to ask important questions. So when we look up at what's called the hierarchy of evidence, a case report, my Aunt Susie had a heart attack 3 weeks after a vaccine. Case series, I've heard about 10 people that had a heart attack after a vaccine. And other lower quality studies are what are called descriptive epidemiology. They ask questions. They generate hypotheses. They don't answer questions. To answer a question, we need analytic epidemiology. And it's that analytic epidemiology where we have a control group that allows us to get closer and closer to establishing causality. The best of these is randomized controlled trials, no doubt about it. But as I said, those are limited in the size and scope because of how hard they are to do, how expensive they are to do. And we're not going to find extremely rare side effects there. To do that, we go to the next best types of studies, which are cohort studies and case control studies. And Vaccine Safety Data Link can be asked to do those. Mine your 12 million people in there and look and see at a huge group of vaccinated people versus unvaccinated people to see if more deaths, more heart attacks, more strokes, or whatever bad thing you're wondering about is occurring with greater frequency in the vaccinated. Here's one of the first published reports on this, again, for COVID vaccine. They said, let's look at 25 bad things, many of which can kill you, many of which were thought maybe this could be a problem from a COVID vaccine. Let's look at these 25 bad things and compare them in a vaccinated group versus a control group. And here they were able to find 11.8 million doses of the vaccine given to 6.2 million individuals. Really powerful, big numbers. And compare those to matched non-vaccinated individuals. What did they find? Found no increased risk of any of the conditions on that list of 25 bad things, except they did find that there was an increased risk of myocarditis, heart inflammation, in young people, particularly males, about a 3.7-fold increased risk. And they found increased risk of anaphylaxis, about 5 to 8 cases per million doses of vaccine given. Pretty powerful data. Let me kind of just quickly touch on these other systems here. VSafe, BEST, and PRISM. VSafe, new system that was introduced with COVID vaccine, brand new safety system, which is going to be now continued and adopted to other vaccines. This was a voluntary CDC smartphone-based monitoring program. Since its launch in December of 2020, 10.1 million VSafe participants completed more than 151 million health surveys. I participated in this, and if you did that, you know, you got these text alerts saying, hey, how's your health? Did you have any problems? Did you go to the hospital? Reminder, please fill out your survey. Active surveillance, much better at finding a truer rate of problems than passive surveillance. The VSafe data have now been included in more than 20 scientific publications on vaccine safety for COVID. It's also been used now for the monkeypox vaccine. New version of this VSafe is going to launch later this year and is going to allow users to share their post-vaccination experience with new vaccines. So exciting new system added to our previous existing systems. Strengths of this is that anyone can enroll in VSafe. You get regular reminders to complete your survey. So it's going to be much better at capturing that safety data. It can quickly validate safety signals from clinical trials or things like VAERS. And the CDC can follow up with participants and submit VAERS reports. Limitations, VSafe data may not properly represent the general population because, you know, who knows, maybe people who sign up to do something like this are a little different than people who don't sign up to do this. So it's not maybe going to be completely representative of the general population. Next system is the PRISM system, which is post-licensure rapid immunization system. The PRISM system is actually our largest vaccine safety surveillance system in the US that probably most of you never heard of. This is a system that mines insurance claims from multiple very large insurance carriers. So, you know, insurance claim is filed anytime somebody has something bad that makes them touch the healthcare system, go to a clinic, go to the ER, go to the hospital. And it covers 190 million people. And so you can do, you again have strengths of large population and this database of insurance claims to identify safety issues. Limitation is that it can lag in time for accessing the PRISM data. Medicare populations is not as well represented, so maybe the elderly may not be representative of those without insurance coverage. So there are limitations. Another system that you very well may not have ever heard of is called the BEST initiative, or the Biologic Effectiveness and Safety Initiative. This is a system that is managed by the FDA. It's a complement to Vaccine Safety Data Link and VSafe. It conducts active surveillance on adverse events, and it looks at large-scale claims data that are linked to an electronic health record. That ability to link it to an electronic health record allows you to have a control group. So one of its strengths is near real-time analysis with available data and the ability to include a control group. Let's look at vaccinated people's claims versus unvaccinated people's claims. Limitations, again, may not be representative of those without insurance coverage, cannot determine if an association between an adverse event and vaccination is causal. That's what the active monitoring. When you do the control group, you can get closer to making that association. This is a summary on one slide of these systems and others that we have. We have Department of Defense systems, 163 million records. We have VA data, 6.4 million veterans. These, and here's several others. I'm not going to go through the rest of them, but we have many different systems to mine data for safety signals. Now, aside from these database mining systems, we also have a system called the Clinical Immunization Safety Assessment Project, or CISA. What is CISA? This is a national network of vaccine safety experts from the CDC that are from 7 medical research centers and other partners. The project addresses vaccine safety issues, conducts high-quality research to assess complex clinical adverse events following vaccination. This is kind of like a strike team that can be called when some strange thing appears. So, for example, when the vaccine-induced thrombocytopenia syndrome emerged from the Johnson & Johnson vaccine, this strange blood clotting disorder that could be very serious. CISA was called in to go and investigate these cases, and they try and do a deep dive on the patients and their charts, and they may set up small studies to try and get at the pathophysiology. And we don't rely only on our own system. We look at vaccine-related data from other countries, which is a big deal. There are a number of other countries that particularly have national health systems. So they have most or all of their population in a single database, which is very, very powerful for being able to do active surveillance and to do controlled studies, cohort studies. Surprisingly, Qatar has been really phenomenal through the COVID pandemic. I didn't know that they had such a high quality electronic medical record, national health database, but they've published multiple really excellent research articles on vaccine safety, vaccine efficacy through the pandemic. The UK has a national health system with the ability to mine their data, lots and lots of technical reports they put out. I regularly went to their technical reports during the pandemic to get very high quality data. Denmark, again, a national health system that allows a mining of nearly their entire population. Excellent studies on large numbers of people. Israel, excellent data, multiple excellent publications coming out through the pandemic that I went to a lot. And South Africa was kind of a star with similarly ability to mine large claims databases in their country. And we had a lot of really good data come from there. I'm going to just show you one example. This was from Israel, similar to a vaccine safety data link. They were able to do the same kinds of things with their national database. Here they looked again at this is like about 26 or 27 bad things that people were wondering about from a COVID vaccine. And they said, all right, let's look at the excess risk of any one of these bad things happening from a COVID vaccine, people getting a COVID vaccine versus people that didn't get a COVID vaccine. But they said, let's go one step further and let's look at those same 26 or 27 bad things in people who got COVID versus people who didn't get COVID. And because they were able to mine their entire population, they had almost 900,000 vaccinated people that they could compare against 900,000 matched unvaccinated people. And they were able to gather up over 170,000 infected people to compare to about 170,000 non-infected people. Now, what did they find? Well, first they found that there was lowered risk in the vaccinated group, that's the blue bars, for acute kidney injury, arrhythmias, and intracranial hemorrhage. Vaccinated people had about 5, 6, or 3 less cases of those things per 100,000 people vaccinated. They did find there was a few things that went up. The vaccinated group had more shingles, had more swollen lymph nodes, and about 3 extra cases per 100,000 people vaccinated of myocarditis. But compare that with what they found in the infected versus the non-infected group. Vastly more problems of acute kidney injury, arrhythmias, deep vein thrombosis, strokes, heart attacks, myocarditis, pericarditis, pulmonary embolism, markedly increased excess risk in the vaccinated versus, in the infected versus the uninfected. So this is that risks versus benefits scale that needs to be weighed. And here the risks of the virus vastly outweighed the risks of the vaccine, at least for that list of about 26 or 27 bad things. Now, I want to kind of finish up just trying to look at how these systems can work together to find and manage potential safety issues. So I use this example of the rotavirus vaccine. This was the face of a baby with rotavirus in the kind of pre-vaccine era in the early 1990s and earlier. When I did my medical training during the winter, especially, there was babies always on the wards with this. This rotavirus would cause diarrhea, vomiting, could lead to significant dehydration, shock, and death. In the pre-vaccine era, there were about 3 million cases of this per year, a little over 400,000 physician visits, about 250,000 ER visits, 70 to 100,000 hospitalizations, and about 20 to 60 deaths. A vaccine was developed, a live virus vaccine. The FDA approved that vaccine based on the phase 1 through 3 trials. Phase 3 trials had a N of about 4,400. You can do your 3 over N to kind of get a number of what rate of serious adverse events this trial could predict. But it's a little bit lower than a lot of the vaccines that we typically look at, but it was approved because this was such a devastating illness to a lot of babies every year. So it was approved in August of 1998. Due to the post-licensure safety monitoring, VAERS found 15 cases of intussusception. Intussusception is telescoping of that small bowel on itself that can lead to obstruction and may need to go to surgery to relieve. And rarely it can even lead to serious complications, including death. It found 15 cases. It didn't find every case. It didn't have to find every case. It just had to find enough to see a pattern, to see an early warning, to see a flag or a signal. And that signal led the CDC to suspend the vaccine and to study this further. So the CDC sent in CISA to do an investigation, like, is this plausible? What's the pathophysiology? They used Vaccine Safety Data Link and other sources to conduct case series, case control study, and retrospective cohort study. The latter two have control groups. They confirmed that there was an association of that vaccine with intussusception and calculated a rate of about 1 out of 11,000 children getting this vaccine had a risk of intussusception. That vaccine was then withdrawn from the market slightly over a year later. Now, what happened since then? There was expertise that said, we think we know why this might have happened with that vaccine. We think we can modify it so that this will be less likely. And new vaccines were developed, one of which was the pentavalent rotavirus vaccine. And you can see in the study here for phase 3, which was done published in January 2006, 34,000 infants in the vaccine group, 34,000 infants in the placebo group. So a really big study. They wanted to really find, as best as possible, even rare adverse events. And then another vaccine, the Rotarix monovalent, that study had 80,000 subjects. Those two studies found no additional risk of intussusception. However, that was not enough. There was still concerns about, could it be even something rare? So the monitoring went on. There was actually some data that came from our partner other countries suggesting there might be a slight increased risk. The CDC initiated a cohort study through Vaccine Safety Data Link that involved 500,000 first doses and 1.27 million second doses of the RV5 vaccine. What did they find? They found that the RV5 vaccine had about 1.5 additional intussusceptions over, the baseline rate of intussusceptions, because intussusceptions can occur without the vaccine too, but about 1.5 additional cases per 100,000 children given the first dose. All right. Now that might lead a parent to say, I don't want that for my child. I don't want to take any risk, even if it's as low as 1.5 out of 100,000. But of course, that's not the math. That's not the complete math equation that needs to be done. It's that balancing of the pathogen versus the vaccine. And when you do that math, if you take a birth cohort, which is typically about 4.3 million infants born in the United States per year, and here it was the year 2000, they looked at these infants up to age 5, and they found that about 45 kids, babies, would get an intussusception from the vaccine. About 13 would get an ER visit because of the vaccine, because of this intussusception, and 0.2 would die, or one over the span of 5 years had a risk of death from the vaccine. Not good. But that has to be weighed against what was prevented by the vaccine. And it prevented 53,000 hospitalizations, almost 170,000 ER visits, and 14 deaths. That benefit to risk ratio was over 1,000 hospitalizations prevented for every one caused, over 12,000 ER visits prevented for every one caused, and over 70 deaths prevented for every death that might occur from the vaccine. Again, your baby is way better off with the vaccine than taking their chances with the virus, which, by the way, infected nearly every infant or child by the time they were 5. It was a nearly universal experience in childhood. Just a few other examples of this. These systems working together: vaccine-associated paralytic polio, a complication of the oral polio vaccine or the live polio vaccine, a rare, very unfortunate complication that the oral polio vaccine can revert to a form that can cause paralysis. This was discovered in VAERS. Didn't have to find all of them, just had to find enough of them to generate a signal. That was then studied in Vaccine Safety Data Link, data from other countries and a few other systems. Yes, an association was found. Yes, an action was taken. The United States transitioned from the oral polio vaccine to only using the inactivated polio vaccine, which is what we do now. A signal came in VAERS and in the active surveillance of Vaccine Safety Data Link that there might be more deep vein thrombosis from the HPV vaccine in girls and young women. That was studied further with a cohort study in Vaccine Safety Data Link, as well as cohort studies in Denmark, Sweden, and Canada. Hundreds of thousands of study subjects compared to vaccinated versus unvaccinated, and the association did not hold up when you looked at it with a control group. And in fact, the association was really found to be linked to women's use of oral contraceptives, which is a known risk for deep vein thrombosis. And so no action was taken. The Johnson & Johnson vaccine, with this rare form of blood clotting, this vaccine induced thrombotic thrombocytopenia, discovered in VAERS and data from Europe, studied with additional data in Europe. CISA investigated it, Vaccine Safety Data Link investigated it, and a VA investigation occurred. The association was found, action was taken, the vaccine use was limited, and the FDA eventually rescinded the emergency use authorization. mRNA vaccines has been associated with myocarditis and pericarditis. Really first came out of data from Israel. Our systems weren't able to detect that subgroup of young males because that wasn't big enough and focused in on enough to detect that signal, but Israel was able to detect it. Then when that was broken out further, we were able to detect it in VAERS. VSafe looked into this. CISA, Vaccine Safety Data Link, did formal studies. The military, the Department of Defense did studies. Other countries did studies. And yes, this association was found. And there has been a partial action. It's still indicated for children and young adults and males, but an optional 8-week interval between the first and second dose was added after this. And that 8-week interval spread in time has been strongly suggested to reduce the risk after the second dose, which is where most of the risk is. Here's a list of other ones. I'm not going to walk through all of these, but these are other signals and concerns that have come up over the years. And I point out several of these here, not because they popped up in any of our safety monitoring systems, but just because the public was concerned. Thimerosal and autism, primary ovarian insufficiency with the HPV vaccine, or aluminum causing problems like asthma. These have been studied with these more powerful systems that we have. Only one holding up here is that there might be an association with aluminum adjuvants and a slight increased risk of asthma. Data from other countries has not borne that out. Denmark just had a study that did not verify this. This action is being taken with ongoing investigation with bigger studies. Well, I hope that this can give you some increased confidence in our vaccine safety monitoring systems and process. I suspect many of you, like myself, when I first kind of got into this with our center, really didn't know about a lot of these other systems that were out there. Everyone's has a stake in vaccine safety. And I hope that it gives you some confidence that we have systems that try very, very hard to find these rare signals. I will stop sharing there, and I'll kind of turn it back to Kylie. I know we're probably right at close to 1 o'clock, and I'm willing to stay on a little bit later if people have questions, and I'm happy to try and entertain questions.
Yeah, we have one question in the chat from earlier, and we'll just continue to keep monitoring. This goes back to a topic you touched on earlier in the presentation about delayed side effects that may occur, weeks or months after vaccination. This participant was asking if you could comment on cardiomyopathy related to COVID vaccination and delayed side effects.
I'll have to confess, I'm not aware about cardiomyopathy. So I think it's a fair question, because if someone got myocarditis, we could certainly wonder, might that have, so somebody said, sorry, myocarditis.
Yeah,
so
it's myocarditis. Yep, she clarified.
Okay, so myocarditis was not a delayed effect. That occurs very quickly after the vaccine dose. It was almost all of the reported cases are within days to the first week or so after the vaccine. It's not a delayed effect. Now, I'll play off that question though. Could there be cardiomyopathy after myocarditis, down the road, like, scarring in the heart or something? Could be, but the immediate effect of the vaccine problem was right after. And here's the reason why, we think most serious adverse events are going to occur in that first 6 to 8 weeks. It's because they either are from toxicity from the vaccine components themselves, or it's from an autoimmune response. That's the vast majority of these problems. The vaccine components themselves tend to be eliminated fairly quickly from the body, usually in hours to days. And autoimmune the immune response peaks around 4 to 6 weeks. So we would expect that most of the things are going to appear when the immune response is at its highest, not as it wanes away. But I don't hold out that this could never happen. I'm just saying, in the history of U.S. Licensed vaccines, we have not found anything that I'm aware of yet that has occurred later than 6 to 8 weeks after a vaccine.
All right, next question that just came in. Given the usual 10 to 15 year time frame for a vaccine drug to be approved by the FDA, how do you explain the rapid approval of the mRNA COVID-19 vaccines? And I think you could throw in the Johnson & Johnson COVID vaccine there too.
Yeah. So it's a good question. I think it's a fair question. I think that was one of the things that made a lot of people concerned about the vaccines, and the fact that it was kind of a novel technology. It's quotes a novel technology. So two things there. One is that a large chunk of that 10-year timeline is often in that preliminary proof of concept, test tube studies, animal studies, and so on. That had all been done. That had all been done with the original SARS virus, which emerged in, 2003, I think. Everybody recognized that these coronaviruses posed a significant threat. And with the original SARS, which killed about 800 people and had a very high mortality, research started in earnest on these. Now, mRNA technology was being looked at for other problems like cancer and other things. Then it got applied to the original SARS coronavirus, and candidate vaccines were even developed. But because the original SARS disappeared, I mean, it disappeared after a little over a year, those got mothballed. But they were able to bring back out that preclinical work and apply that to this. Then the clinical trials, the FDA, under the emergency use and under Operation Warp Speed, which that name bothered a lot of people, allowed for a rolling process of phase 1, 2, and 3, so that they could be stacked instead of waiting for each one. So like if phase 1 was progressing without any major safety signals, they allowed the company to start phase 2. And then phase 2 rolled out. And if that was looking okay, they allowed them to start phase 3. But they had to finish those. And it was a public health emergency. It was under emergency use authorization. That is not the normal way vaccine approval goes. It was a very unique situation where, we lost 1 million people. And in many respects, we got lucky with that vaccine.
All right. I am not seeing any other questions. So I just want to thank everybody for joining us this afternoon. If you have any other questions or feedback, please feel free to reach out to us at ndsu.cire@ndsu.edu. Thanks, everyone, and have a really great rest of your week. Thanks, Dr. Carson.
Thank you. Have a great rest of the week.